Welcome back, everyone, to the transplant ward. We have a post bone marrow transplant patient with features of acute liver failure. In this setting, we always suspect a microvascular veno-occlusive disease, but we must check for the major vessels first. So now let's deep dive into the axial cuts, CCT axial cuts of this patient. And one thing I want you all to notice is that the IVC is patent and showing good enhancement with the contrast. If you track it down, you will be able to see that there is good enhancement in the IVC. All right, it can be appreciated really nicely on the coronal sections. But now, what about the hepatic veins? If you start seeing, you will see that the hepatic veins are not showing any contrast enhancement. The middle one, the left one, and the right one. Let's track them. You can see them draining into the IVC, but there is no contrast enhancement. Why this has happened? This has happened because the microvascular veno-occlusive disease that we sometimes see in a patient after bone marrow transplant has now converted into a Budd-Chiari syndrome, and we can see a massive thrombus in the hepatic veins as of right now. So as the main outflow is in shock, the parenchyma of the liver, it starts to, because of the blockage of the main vessels, the parenchyma goes into the shock. So if you will also see the enhancement pattern, it you can see that there is early changes of mottling, and the liver is the it's little bit hypo intense as it would have been in a normal case. So what can we do as of right now? So in these patients, you cannot treat a hepatic vein clot just with the supportive care like anticoagulation and all. This patient needs immediate decompression to prevent the hepatic necrosis. So in these patients, a tip stunting, rather dip stunting, because as we have discussed here, we can't see the origin of we can't really see any hepatic vein which is without the clot. The clots are there, the thrombus is there from the origin point itself. All right. So in this case, we will rather go for a dips stunting, where we'll directly puncture the IVC, and from the IVC we'll directly go into the portal vein and establish a stunt that can bypass the flow of the blood from the hepatic veins directly into the IVC. So the important takeaway point is that the post-transplant patients are highly prothrombotic. So always make sure that the hepatic veins are patent before we call it a veno-occlusive disease. If we are not able to see any sort of enhancement pattern in the vein, then we will definitely go for a Budd-Chiari syndrome rather than a veno-occlusive disease. Thank you. Have a nice day ahead.